Good afternoon, everyone, and welcome to the fall edition of UHN Foundation's Behind the Scenes Lecture Series. My name is Christy Spencer, and I'm Vice President of Stewardship at UHN Foundation. We at UHN Foundation are very committed to providing you, our tremendous donors, with the most up-to-date information about our healthcare system. And this afternoon's presentation is a way for us to thank you for your continued generosity and support. I'm incredibly honored and privileged to introduce the important conversation we'll have today. As a Canadian, an 8th generation Canadian, I've always been proud of my heritage. As I've begun to learn more and reflect on the true history of our country, I now understand that it was built on, and sadly in spite of, the lands of many Indigenous nations and communities. Conversations like the one we're having today are important for all of us to be a part of, so we can continue to learn and hopefully become better humans. With this in mind, it's also important for us to begin today's conversation by acknowledging the land on which UHN operates. Long before this country was called Canada, it had been the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this is still the home to many diverse Indigenous people from across Turtle Island who have and continue to enrich our communities. Over the next hour, I look forward to learning and understanding further, along with all of you, about the work that UHN's Indigenous Health Program aims to achieve. Established in 2020, the program's mission is to improve access to high-quality, effective healthcare for Indigenous peoples and ensure that Indigenous knowledge, values, and voices are present and respected. This work is guided by Indigenous communities, and the strategic priorities align with the calls to action of Canada's Truth and Reconciliation Commission. This afternoon, the team will be able to tell you more about the critical work the program is doing every day and how they're working to find new ways to better serve the broad Indigenous community in Toronto and leading the way to better access and high-quality care. It now gives me great pleasure to introduce Dr. Lisa Richardson, who will moderate the conversation with the Indigenous Health team over the next hour. Dr. Richardson practices general internal medicine at UHN and is a researcher at the Wilson Center with a focus on the integration of Indigenous and critical perspectives from the social sciences into medical education. She is the Associate Dean of Inclusion and Diversity at the Temerity Faculty of Medicine at U of T and is the strategic lead in Indigenous Health for Women's College Hospital, where she founded the Center for Wise Practices in Indigenous Health. Dr. Richardson was previously a co-lead for the UHN Indigenous Council, and her work on this council was instrumental in forming the Indigenous Health Program here at UHN. Lisa, we're so thrilled to have you and the team joining us today. Welcome to all of you, and over to you.
Thank you so much for that introduction, and what an honor to be here in the room with this amazing team and to really think about the history of this program and where things are right now. So I do practice general internal medicine here. I love working here at Toronto General Hospital. I've worked at Toronto Western Hospital. I've had many patients at our other sites as well, and noticed long ago that Indigenous peoples, our own community members, were not receiving necessarily the same high quality care, and that this was a real gap. And so quite a few years ago, we formed the Indigenous Health Council, which was an amazing group of leaders at UHN who were some Indigenous and some of us not, and some non-Indigenous. My background is Anishinaabe, and Bernice Downey and I co-chaired that committee and started to advocate for the needs of our peoples within this hospital, these hospitals, and said, look, we need access to navigators, we need people to be able to smudge, we need people to be able to see their own healers and have care providers who understand that perspective. And so slowly ended up advocating for the creation of the hiring of a strategic lead and the hiring of Ashley and of Len Benoit, and to now look at the team and see how things have grown is really deeply inspiring. To be down and emerge and see our patient and see one of our own people, an Indigenous patient navigator, Victoria, supporting our own people is so wonderful. And so here today, we're going to talk about the work that you're doing now, where the Indigenous Health Program is at, and where you imagine things will go as well. So I'm going to start with having you introduce yourselves, and we'll just go across the in a row here. So Mike.
I am Mike Anderson. I am Mohawk and mixed European. My family roots are in Tyendinaga Mohawk territory. I'm Bear Clan. Pardon me, I consider myself part of Toronto's urban Indigenous community. I'm born in Scarborough, raised in the GTA. This is the community that I call home. I'm the strategic lead of Indigenous Health Program at UHN. I'm a surgical oncologist and palliative care physician by training, and I work with this exceptional team.
Saigo, my name is Chantal. I am Haudenosaunee Mohawk from Bay of Quinte and European descent. I sit with the Bear Clan, and I am the Emergency Department Indigenous Patient Navigator for Toronto Western Hospital.
Ani Ashley Migoans Dishnikaz, Chiging Donjaba, Chike Dodam. So my name is Ashley Migoans. I'm from Chiging First Nation, which is located on Manitoulin Island. It's about an 8-hour drive north of Toronto here. I'm a Turtle Clan in Anishinaabe. I was born and raised back home in my home community of Chiging. And I had worked there for a number of years before I moved to Toronto here, and I've been living in the city now for about 9 years, working at UHN. And miigwech.
Ani bojo naboeg and music shikwakwe disnakaz makwadodem wukamakon dojaba. So my name is Victoria Mantwabi. I'm from Wukamakon unceded territory located the same on Manitoulin Island. And I'm the Emergency Department Indigenous Patient Navigator here at Toronto General. So, miigwech.
Thank you so much. And it's amazing to hear everyone introducing themselves in a more traditional way as well, and understanding the connection to land and community. And I think that's one of the things that this program has done so well, is it's bringing together two worlds, the worlds of medicine and healthcare and Indigenous communities, and bridging that. So to start off in thinking about the Indigenous Health Program, Ashley, I wondered if you could describe it.
Sure. So the Indigenous Health Program, or an Indigenous staff program, each of us all carry very diverse lived experiences ourselves as well. First Nations, but all from different nations, different lived experiences. We're a small but mighty team of 5 people currently, with Mike providing more of a strategic direction for the program. Myself, I'm the manager for the program, and then we have 3 amazing Indigenous patient navigators that work with the program. 2 that specifically work within each of the ED sites at UHN, and another navigator, unfortunately is not here tonight, but a very important team member. His name is Leonard Benoit, and he provides support throughout all sites at UHN. As a team, we provide that strategic direction to the organization with regards to Indigenous health equity. We provide direct staff support, whether that's providing support to Indigenous staff at UHN, or whether it's providing education or support, strategic planning for departments and programs. And we also provide direct patient support for patients and families, and that's done directly through the work of the navigators. As Christy had shared in the introduction, we're really looking to improve access to high quality care for Indigenous patients and their families when they're receiving care at UHN. And we're really, really looking to have our Indigenous voices and knowledges and values present and respected at UHN. And the program itself, we ground ourselves in some Anishinaabe teachings, but they're really teachings that many different nations of Indigenous communities do hold. So the 7 grandfather teachings, truth, wisdom, humility, bravery, respect, honesty, and love. We carry these values with us in our everyday life, but we also bring those values into the work that we do through the Indigenous Health Program as well. So those are our reminders in the work that we do to make sure that we embody those teachings in the work that we're doing here at UHN. Another unique aspect about the work that we do is that we do approach our work from a holistic lens. So we do look at, mental, physical, emotional, spiritual health. And our accountability for the program, first and foremost, we're accountable to the Indigenous community, listening to the Indigenous community, making sure that what they share to us and to our program, that we're running on the ground to put that into action here at UHN. So we're accountable to the Indigenous community as well as to UHN overall.
Thanks so much, Ashley. And it's really cool actually to think about when we started with the council to, doing all of those volunteer hours to just get things to make this space, and to now see this amazing team. And it actually makes me really, really proud to be part of an organization where there has been that commitment and where there's an understanding of the truth of what's needed and the courage to act and and the love, like the commitment to doing the work. So it's one of the reasons I do feel really excited about working here at UHN. But it makes me also think about how we need to constantly convince people about why Indigenous health matters, Mike. So can you speak a little bit to that, and why should we care about Indigenous health, those who are non-Indigenous especially?
Yeah. So with the Truth and Reconciliation Commission, I think a lot of Canadians started to begin the journey of learning more about the history of this place than they had been taught in school, that they had naturally been aware of. And I think it opens an interesting and valuable space. So the first part of the notion of truth and reconciliation is truth. And Commissioner Justice Murray Sinclair talks about education is what got us into this mess, and education is what will get us out. So we have to start with truth, and that involves a lot of understanding, and some of it is hard to hear, but it's important. Reconciliation talks to the work that has to be done. And we choose to use the 94 calls to action, the calls to action that arose from the Truth and Reconciliation Commission, as a roadmap for the work we do. There are some that are very specific to healthcare, and some that are less specific but definitely impact healthcare, and we commit to that. So some of the truth part is recognizing that we continue to see poor outcomes in many health measures for Indigenous folks, and the deconstruction of that is many of them are about barriers to care, barriers to accessing care. They're not about genetic phenomena, they are about the system has barriers in place, and often you don't see them until you see them. And we have increasing evidence of what they are. Things like learning that when Indigenous folks show up in an emergency department for the same condition as a non-Indigenous person, they get triaged to a lower priority. In the city of Toronto, we know that the vast majority of Indigenous adults delay attending a healthcare institution for healthcare issues, specifically because of racism they know they'll encounter. Our work, I think, falls under two kind of big buckets. One of them is we have to support community members right now to improve their access to care. The second bucket is we have to change the system within which we work and live to remove these barriers. Both of them are important mandates in what we do, supporting people today in the here and now and changing the system globally. I think the other part of changing the system globally is that affects everyone. So is it important to remove barriers for Indigenous people? Absolutely. In the course of doing that, hopefully we change the healthcare system so that everyone has an opportunity to receive better care. What does that look like? That looks like the navigators we have here who support community, who build relationships. But that also looks like bringing Indigenous ways of knowing, being, and doing into the work we do. So it's not just what we do, it's how we go about doing it. We, as Ashley said, we are accountable to community. We're accountable to the institution within which we work. We're equally importantly accountable to the community we serve. So we try to bring Indigenous knowledge and Indigenous ways of being into the work we do. That looks like taking knowledge systems like the medicine wheel, which speaks to the wholeness of humans, our realms, our spiritual, our emotional, our mental, and our physical realms. And we actually tried to use that as a model for how we deliver care. And that's crept into some other parts of how the institution works. Things like attending to critical safety events that aren't just physical harm, that recognize that spiritual, emotional, and mental harm are equally valid harm, equally problematic. So we work to change the system. That's complicated, that's a long game, but it's important. And it's important for Indigenous people, and frankly, it's important for all human beings.
Yeah, and I love that idea, Mike, of talking about the medicine wheel, or talking about the teachings, and the importance of culture as medicine, and the protective role of culture, because often when we're talking about Indigenous health, it's more of what we call a deficit-based model, particularly the way it's taught. It's been taught traditionally in medical schools, and what we see in universities is, well, here are all the gaps. Actually, let's focus on the strengths and how those strengths can actually help care, not just for Indigenous peoples, but will change the whole environment of these hospitals that we're working within, and make them more inclusive places more broadly. So it does lead me, though, to think a lot about navigators and the hugely important role that you both play. It's certainly one of the evidence-based interventions we know to actually support the care of Indigenous peoples, but I wondered, Victoria, if we could start with you, just describing what is an Indigenous patient navigator and what do you do?
Yeah, so what do? So as Indigenous patient navigators, what we do is we support community members coming in. We support community members on their healthcare journey. So that's, coming right into the emergency department, from being admitted to any of the floors to follow-up appointments here at UHN. That's the support that we do. We also, as we were mentioning, we do follow the medicine wheel care model for emotional, spiritual, mental, and physical. So we, as navigators, that's important to us. So we're hitting all 4 aspects on their care journeys. Another things that we do is we provide traditional medicines for community members on their care journey. And then we also provide some education to different departments in the emergency department of simple things of what is a smudge, little bit of the history to why these traditional medicines are very important when community members are coming in. We also build, our main goal is build trust with our community and our community members and their families, building those relationships. Another thing is that we do is, we do a lot of outreach in the community, because when we first started, me and Chantal, we knew how important it was just to let the community know who we were as a program, and building those relationships with each other, sharing in a circle of our ideas and what community wants. What else do we do? I guess that's a little bit brief that we have done. Yeah.
I think one of the amazing things that both you and Chantal have been doing, and Leonard, is that patient advocacy piece as well. Being able to sit, if there are any incidents that do happen to occur, being able to sit there with them and making sure that their story is being told, right, and being shared, and being able to support them through that as well.
I think you used a word that's critically important, which is trust. And I work in a community setting, and I hear regularly about the good work you do because it feeds back to community. That's amongst the biggest barriers. And when community members start talking and community agencies start talking about the support they receive, that word spreads. just like negative words spread, positive things spread too.
Yeah, Conrad Prince, who we'll probably talk about in a bit because he's the new leader of the Indigenous Health Action Network, recently said to me, for Indigenous health, we move at the pace of trust. And so your presence and your visibility within the institution is so important. And I've seen, when I observe you down in the Emerge, and I see you at the bedside of an Indigenous patient, you can see just the relief. It's like this visible relief to have a community member there, someone who is present. So it's really powerful. We can't underestimate that. I'm wondering though if we can think a little bit more about if the Indigenous Health Program is changing the system. I'm going to throw that one to you, Chantal.
Thank you.
You get the hardest one.
Thank you. I think that we change the Indigenous Health Program here at UHN and the Indigenous patient navigators, both in the ED and throughout UHN, are really kind of breaking down that systemic barrier and systemic experiences of racism that happen within community care. So we are creating these spaces of safety for our community members. We're creating spaces that are built upon trust and reciprocal relationships. We're not just coming in at the last minute and saying, here we are, you're going to be discharged, and this is what we're going to do for you. We're sitting with people from the moment they're entering into hospital. We're continuing if they're being admitted. We're helping with follow-up care. We're making referrals to outside organizations because we are building those relationships through outreach with community organizations that have long-standing relationships with community members. To highlight that, I'll tell you a small story about somebody that I seen in the emergency department at Western who has agreed that I can share her experience. So we had an elder in the community who came into Toronto Western, and originally she was seen in a community clinic where she was informed about the IPN role in the emergency department from the community nurse. And the community nurse, with the elder's permission, was able to give me enough background information that I could share with the emergency department doctors while she was coming in. And she came in and I was able to meet her right at the door. And I was able to walk through the entire process of registration, triage, sit with her. Small things like, can I offer you a cedar tea? Can I bring you a tobacco tie, because I can see that you are incredibly anxious in this moment because this space is a little difficult for you to be in and navigate. Let me step in and help you where you need to. And over this, she, excuse me, over this, she explained to me that her husband was at home, very anxious for her, and unable to be in the emergency department with her. So him knowing that I was present with her was able to take away some of that concern for him. So we're not just supporting it's patients, we're supporting their families as well. She has had to come back to the emergency department over multiple visits. She calls me directly when she's coming in and says, Chantal, I will be there. I'm on my way. I'll meet you. She will send me a quick text message after she gets discharged saying, I've been discharged, I'm home safely, just to keep that relationship of trust together. And she knows that when she comes in that I'm going to be there and I'm going to sit with her, and that takes down some of that barrier to when she's willing to come in and access care. And so, that safety and that trust is one of the ways that we are changing the system. We're also changing the system with, as Victoria had touched upon, with education. We're educating our coworkers on a regular basis in the emergency department. We're educating new emergency department hires. We're teaching people what a smudge is, so that way when they smell it in the emergency room, because we will smudge directly in the emergency room if a patient requests, those things are being talked about amongst non-Indigenous staff, and that's taking away barriers for people when perhaps maybe myself or Victoria or Leonard are unavailable and somebody says to a staff member, I'd like to smudge, or I would like access to my medicine pouch, or I would like you to store my medicine pouch safely. How do we have these conversations? And it's done through education that we're being able to provide to the overall UHN staff.
That the story of the patient that you supported is just, it's unbelievable. In that it makes me think a lot about my own practice doing acute care inpatient medicine. And those highest risk times are the transitions in care and leading to significant gaps. So I want to point out what you're doing as an example that could be of the leading practice, not just for Indigenous health, but for the whole health system. Understanding why continuity of care is important. Understanding that also this idea of seeing the whole patient, because so often I hear from my patients that they don't feel seen as a human being, right? Or not from, hopefully not my practice specifically. I try to be more comprehensive, but this idea that the healthcare system can be extremely objectifying and dehumanizing. So seeing the whole person is powerful, and another example of how you're changing the system by teaching others who observe the way you care for people, the way you're respecting people as human, as whole. So I really want to highlight that, because I think this work, again, it's about shifting from the strengths to a strengths-based model. Mike, what do you think the future looks like for the Indigenous Health Program? And then maybe we'll go down the whole row, because I'm sure everyone has thoughts about that.
Yeah, a couple of things. I think one of the things that we kind of knew, but you see it when you have navigators, is I don't think institutions always know who their customers are, who we serve. So there's a lot of false impressions of who Indigenous people are, where they live. And once you have programs in place, you start to see people identify and use the support. So it's very hard for institutions to actually understand who they serve. And that's particularly true, I think, with Indigenous people. Once you have programs and you can say to someone, hey, we have this support, all of a sudden you start seeing more and more Indigenous people identify. You know, they reach out to you. We can't change something that we don't actively know about. So one of the things that happens is, as we provide supports, as there's programming, people start to identify. We start to learn, how do we really support people? I think one of the challenges when you ask, where do I see us? A bit of that answer is, we don't necessarily know, because we're learning who we serve. I think it's important that we do that work. But I'm going to echo what you said, which is, we are too often framed by our deficits, and that negates the ability to see all the beauty and strengths that are inherent in Indigenous communities. So if I had any sort of vision post, it would be to see Indigenous knowledges, ways of being, its strengths, change and incorporated into healthcare. That sort of at a high level, that would be a great direction.
That. Chantal?
I think I see a change moving towards including more traditional medicines in our care, and the respect for our traditional medicines. So when we have these conversations about providing not only our 4 sacred medicines, but traditional medicines in general to patients, and how that relates to not only their physical care, but their spiritual, their mental, and their emotional care while they're in hospital. I think that that's something that I see us working towards in the larger scheme of the institution, but also creating spaces for our community members to say, wait a second, I would really like to have this medicine that my healer has suggested that I take while I'm in care. I would really like access to traditional medicines while in hospital. And I think that that's an important thing that we move towards.
So important, and we know from the regional health surveys for First Nations, for example, that 50% of people or more actually say that they want to access both traditional medicine and Western medicine. So I think we're realizing as practitioners in this Western medical system, we need to be teaching our future practitioners how to have even the conversations to broaden the team, right? To make sure that we're offering, that we're considering that our patients may be using traditional medicine or may want access to it, and to build those networks. So having a program like IHP really can help with that too. Ashley, what do you think about the future? What's the future of the Indigenous Health Program? It's
exciting,
like bigger and exciting.
Exciting thing to think about. I think just thinking about the approach that we've taken up to this point is, you know, we really look to the Truth and Reconciliation Commission calls to action. So we chose to focus on just getting closer towards what Chantal was sharing. For the first year or so, we had decided to focus on call to action number 22, which is incorporating you know, Aboriginal healing practices into the care we receive, which is exactly what Chantal had shared. Another call to action we focused on was number 23, which is increasing the number of Aboriginal health professionals that are working within the healthcare spaces. So when I'm thinking about the future of IHP, I'm thinking about increasing those staffing opportunities, not just for within Team IHP. I'm thinking about the organization overall. So, you know, working with our HR department to try to do some targeted recruiting to get more Indigenous peoples working at UHN. It's important for our community members to see ourselves throughout the organization, not just in an Indigenous specific program. So that presence throughout, I think that that presence, Indigenous voices at those leadership tables with senior leadership, a board member in the future, you know, really thinking about bringing in more Indigenous patients into any circles, or, you know, informing the care that we provide, right? We need to listen to them to know what the needs are. I'm thinking about our navigators here. We have 3 navigators working across all sites at UHN. We need more navigators. You know, they're so busy. Thinking about after hours support, thinking about weekend support, thinking about program support, additional support needed there. We're also thinking about, you know, thinking about increasing Aboriginal health professionals. So what about helping learners as they're getting into careers? You know, providing, creating a summer learners program where we can support Indigenous learners at UHN, getting mentored by Indigenous staff at UHN as well. Thinking about an elder in residence program, so making sure that we have, you know, that we have them on staff, on hand when needed. Traditional healers on staff, like, you know, like this would be just so amazing. I'm like excited thinking about it.
It's awesome.
The possibility, yeah.
Yeah, and I think acknowledging, given this event, how the commitment of the foundation and philanthropy has allowed so much of this growth, which I remember being involved when TD Bank was first thinking about supporting the navigator roles, and look at what you've done now. So I think, as you and I were just saying, we have to recognize that we can't do this work alone, right? And so always so grateful for the support. Victoria, what do you think about the future?
I was like, oh, no, I'm just joking. I think it's very important to share what I think. I was going to take some pieces from what Ashley was saying. It's really great to work with a team. I can't imagine doing this work with just one person. So just seeing the team grow, and then also, as you mentioned, to bring more recruitment of Indigenous people into the space. I would like to see more of us, as Indigenous health is growing, not just in Toronto, but all over on Turtle Island, of doing more of those connections, of learning what do you guys do, and what do we do, and just having those sharing circles with each other. And then also every day I'm always keep learning from community members and their families. So just sharing those knowledges within amongst each other of like what I learned just yesterday or today. So just having those conversations. So that's something that I'm looking forward to. Yeah.
I love that idea of the network too, across the province. And Mike, early on, you and I had this dream about even creating a network within Toronto, and I wondered if you wanted to speak a little bit to how UHN has played such a key role in being in that network development.
Yeah. So I actually think you touched on something, Victoria, which is it is really hard to do this work alone. Alone is I think a vulnerable position. The way to do this work is collectively, to support one another. And early on, we started to recognize that hospital A might have something figured out, but not this, and another one would have something. So working collaboratively is the way to go forward. So there's the development of the Indigenous Health Action Network. So that's Indigenous Health Program leads or strategic leads within each of the academic hospitals collaborating, working together to share what works, to learn from one another, to support one another. And I think that gives us an ability to sort of have an amplifying effect beyond what all of our programs are individually small, but it gives us an ability to collectively have more impact. I think it's critically important. We've seen through the city and other places that a single person in a single program often gets knocked over. And so we have an ability to support one another, to share best practices, to learn. But I do think it's that amplifying effect.
And I think, often what I hear the conversations around that network table are, well, if UHN, which is a huge institution, which has many different sites, very quaternary programs, primary care programs, they're doing this. So, maybe we can consider building our Indigenous Health Program too. So I really want to acknowledge the importance of that, both supporting but also setting an example that I think is critical. We do have some questions from the audience. I think that maybe we could go to now. Does that make sense?
Yeah.
I wanted to add one more thing, actually.
I was going to jump into this.
Always so much to share, but I'm thinking about the future of IHP, thinking about creating more spaces as well. Currently we're in the early stages of developing Indigenous health and wellness spaces at Toronto General and at Toronto Western. Still a lot of work needed there, but early stages, and ideally, we'd have these spaces at all UHN sites, not just at the two. So thinking about the indoor spaces, but also those outdoor spaces. We do have Michinargitigan, which is the Anishinaabe word for garden. And it's a space where we're growing, the 4 sacred medicines, as well as many other plants that can be used, the traditional uses of plant medicines, right? The space is used for teaching, for harvesting. All the medicines we grow there, we use for patient care throughout the whole year. But again, with that program, we're in the early stages there too. We install the garden, we're using some of the medicines. Now we want to do more, right? Like more artwork thinking about in that space. There's so much future plans there that we would love to proceed and even having more of those spaces throughout UHN as well.
Yeah, and that garden is incredible. I'm sure that if people want to visit or learn more, they can reach out to you about that, because it's a pretty special place to walk through.
And I'm going to add one more to it. We're accountable to community, and part of that means listening to community. And a year ago, we had a couple of community engagement sessions where we had, I think, 90+ community members giving us feedback on what we do and what's important. And one of the things we certainly heard was that people who are residential school survivors talked about, when I enter a hospital, the cleaning solution takes me back. So you start to realize there are things about institutions that most people might not even be aware of. that were very off-putting to people, that were a barrier to coming into healthcare settings. So when we talk about, making places, whether it's the Gitagon or whether it's healing space, people say, I don't see myself anywhere in these institutions. They don't, and it's institutions broadly. The work to make institutions feel accessible is important. And we heard that, and these are long-term projects. They involve lots of different things, but they make a difference.
And physical space and land-based space, so gardens, routinely comes up in reports across the country as being really foundational for Indigenous peoples in institutions. So these physical spaces represent so much more. Not only the gathering space and the space to practice ceremony and use medicines and be connected to the land, but I think it's like a metaphor for creating space and being becoming a part of an organization or being recognized within one.
And space is interesting. The garden, the Gitagon, it's not just about growing the medicines. It's that when we do planting days, all sorts of people from different UHN departments come on their lunch hour and contribute for half an hour. Informal conversations, relationship building happens. We have elders do teachings there through parts of the year. It gets used as, it's a bridge to many things.
Yeah. I'm looking at the questions on the screen. So should I be reading those out, or can everyone see them? Maybe I'll read them out. So, is the Indigenous Navigation Team available for all conditions, illnesses, injuries entering ER? And can the team be accessed at later stages of care, example in specialized rehab? So, Victoria or Chantal, do you want to respond to that one?
Absolutely, I can start, and Victoria, if you want to add. So we are, as Indigenous patient navigators in the emergency department, we are available for any sort of entrance into the emergency department. Once we see you in the emergency department, we will, and if you are admitted, we will ensure that you have follow-up care from our coworker, Leonard Benoit. And if you come in for admitted care, we will connect you. So you don't come through the emergency department. We will connect you with our team and with our services. So that way people are getting care regardless of what stage they're entering into Toronto General, Toronto Western, or our rehab facilities as well.
Building on that, connecting to others is the next question, which I'll read out loud. Is there a mechanism to connect the UHN Indigenous navigators with other specialized navigators, example, mental health or cancer navigators, to link ways of being, care pathways, and complex healthcare system or service needs? So how do you intersect with the other navigator programs?
I might even step one, a little bit out of that, which is the navigators routinely reach out to community agencies that might not really necessarily be navigators per se, but for support. So no one space has it all figured out, so you're always trying to reach across to find who can help, who can support in different spaces. I think you do that all the time.
Absolutely. So we reach out to community nurses, we reach out to case managers, we reach out to supports within community, different organizations that serve our community members.
Internally as well, all of our navigators have close relationships with social work teams, with the peers, with the CHWs, the community health workers that work with the social med program. Leonard Benoit, who's another navigator with the team, he works with the Indigenous Cancer Program, and they also have a network of all the navigators throughout Ontario as well. So we try to talk often, talking often.
And in Len's case, it's not unusual for somebody who is coming to a UHN site for very specialized care to be coming from a community outside of the GTA. So, if he was, I'm going to be Len in his absence, but he would reach out to other navigators in other regions and say, how can we support? How can we manage transportation? How can we manage accommodation? How do we do that together because Toronto can be an intimidating place if you aren't familiar and you don't live here. How can we do this?
Victoria, did you have anything that you wanted to add around navigators liaising with
they
others?
all said it.
So the next question is going back to the systemic change. In what ways is UHN making systemic change to incorporate equity and cultural safety principles as part of the health system? And how is UHN making practice space for traditional wisdom systems? I think we've touched a little bit on the latter, but perhaps start with the idea of equity and cultural safety principles. I don't know if you want to start with that, Mike.
Yeah, so we try to highlight a call to action that we're going to tackle each year, recognizing they're all ongoing. And one of the things we're framing around this last year has been cultural safety training for healthcare workers. And one of the things that's been particularly rewarding is to realize that we can't do all of that work, is to find that there are some departments who of their own initiative have taken on cultural safety training, saying we're going to ensure our entire department does that. And that looks like everything from online courses to a few departments have done land-based learning, really in depth. So in that space, there's some things that we drive and a lot of things we support. So sometimes it's enough, but sometimes the start is to highlight that it's important, and then you find that some people just take it on, and that's particularly rewarding.
Yeah, I love that. It reminds me of a teaching that is also written in Richard Wagamai's book, one of his books about, and I've certainly heard this traditional teaching as well, but for those who want to read more, they can find it in his work about the pebble that drops into the still lake and the ripples. So you may feel like you're just having that small impact, but then the ripples that go out and move in those concentric circles beyond it, and the huge effect that you're having. So even though you may feel like you're still a small program, what is happening across the network as a result of your work and hearing about the work that you're doing or knowing what you're doing is very powerful. It's rippling out for sure. How is the Indigenous community participating in this initiative and, quote, consulted with?
I guess the outreach work that we have both done, not just me and Chantal, but the whole team too as well, is just, sitting with them, having those conversations of what does community want, and, how can we work together for community so they could provide a safer care and sorry.
I think like our team, we're all members of the Indigenous community as well, right? So a lot of the work we do is based on our own personal experiences. We know that we don't represent the entire community either. So one of the things that we're looking forward to developing is an Indigenous community advisory circle. So we're looking to have a community tell us, what are the needs, what do we need to do. Mike had also mentioned that we had a gathering that we hosted at Native Canadian Centre of Toronto, where we had 90 community members come out to share their experiences with us. And that's something we're hoping to do on an annual basis, so that on a regular basis we're hearing from community and having that inform the work that we're doing.
Can I highlight why it was important how we did it? If we held it at an institutional space, we would only hear the voices from people who feel safe to come into an institutional space. So we held it at Native Canadian Centre intentionally to make it available to people who don't trust or don't feel safe in healthcare, so that we didn't suffer the challenge of only hearing voices that actually felt okay in these spaces, of hearing people who might not feel comfortable to walk into a hospital, but they would feel comfortable to walk into a cultural community center. And hence we had everything from teenagers to octogenarians.
Yeah, amazing. There is a question about how can community groups, i.e. support groups, connect with Indigenous communities? What resources are available and where can I find them? I'm not sure if anyone has thoughts about that. I think often there may be specialized support groups for people with certain medical chronic conditions or doing other community-based work who may be wanting to offer their supports to Indigenous folks as well. And so I think that's probably where that question's coming from.
I often use the unfortunate metaphor of it's often good to date before you marry. And I think if you're doing that work, it is good to build a relationship and listen first, even though I think the way the question's asked, there may be support groups that have something to offer, but I still think it is good to listen first.
I don't want to end with the biggest challenge question, so let's take that one next, and then we'll have time for a few more questions afterwards. What is the biggest challenge your program currently faces?
Growth.
I was going to say capacity.
Capacity.
You know, yeah.
It's a funny lockstep. When people start to know about you, they want more, which is wonderful, but then you don't have the capacity to deliver on it all. So it's that balance of the demand is increasing and trying to match it with the supply, the service.
One of the elders I work really closely with, who's an Anishinaabe elder, Bannaconda Kennedy Kishbel, she talks about building this small fire and then people will come. And that's certainly what you've been doing. You've got a lot of people coming.
Can I add
yes,
to that?
yeah.
So I think that I absolutely agree. Growth is important. There are days where we will see anywhere from, I think my biggest day was 7 patients in a day, with no ability to stop. But I also think one of our biggest challenges is kind of getting people to feel that they can come into the hospital setting and not have, stereotypes thrown at them, and not have questions that are uncomfortable or based in stereotypical racism asked to them. So that education part that we are working on and some of those barriers that we're taking down is really important for the effects that our frontline experiences of community members are feeling. So they're not being asked questions about that can potentially be harmful and hurt their experience while in.
And actually the biggest challenge becomes sometimes the biggest success, which is some of the places where, we walk through this system and we're part of it, and there's lots of parts of it that become background that you fail to see. And that's a real problem. But the flip side is we've seen lots of amazing allies, or as Len and I would, like true co-conspirators, who once they see it, they go, now I see it all around me. Now I'm going to take action. So the inability to see the things that are just sort of part of your everyday and you kind of accept or you don't notice is a huge challenge. But once people see it, then they go, now I see it all around me, and now I can't unsee it, so I have to do something about it.
It makes me think about an example from my own practice on the general internal medicine wards where there were concerns about people being able to smudge. So, and it was quite a significant concern that emerged. And then just last time when I was attending on the inpatient unit, hearing the charge nurse say, well, we need to get can we call for an Indigenous navigator? The patient wants to smudge. And they seemed to know everything about it. It was like there was no barriers. It was just offered to the patient, and they wanted me to go and introduce myself to the patient, even though just so that they knew there were, friendly people around. It was really fascinating to see that shift in a very busy clinical environment in such a short period of time, I think because of the work. So with that discussion about smudge, I'm going to go to this next question. How can I advocate to receive traditional medicine practices when admitted to a Western hospital system? Who wants?
Navigators want to.
Ashley or?
I can start. First, I think it would maybe just checking whether whatever hospital you're visiting, whether they do have an Indigenous Health Program, whether they have Indigenous navigators. if not, seeing what other supports there are in the community that you're attending, like in Toronto, there's Anishinaabe Health, there's community organizations you can reach out to. But I think a really important thing for community members to know is that, you know, it's a right of ours to practice our culture, right? You know, when we're thinking about the Ontario Human Rights Code, we do have rights that are built into the Ontario Human Rights Code to practice our culture. And as a healthcare setting, it's our duty to accommodate those. That's the language in the legislation. I don't quite like that language of accommodation, but you know, it's our duty as healthcare staff, as an organization, to make sure that we are able to access that.
Yeah, and I just want to point out, like, our ancestors had to hide those practices for many years. So now we're sitting in space where we can embrace our culture and have those teachings, and just having a smudge could go a long ways for someone on their healthcare journey.
And I think maybe in case the audience doesn't know, Indigenous ceremonial practices were outlawed in this country from 1880 to 1951, I think. So we're the original people in this space. We're also the only people who have had our spiritual practices outlawed. So sort of an interesting challenge when we were banned from practicing. So now we're doing the work of reversing that. I also, excuse me, I think there's a word in there that sort of speaks to another element of the work, which is advocacy. Learning how to advocate for yourself is critically important in healthcare. And different communities learn that differently, and I think that's a big piece of teaching Indigenous community members is, what are your rights?
Yeah.
How do you advocate for yourself? And don't, there's an effective way to advocate, and I don't know that we always have taught people that. I think that's another piece of the work.
I think that's really important, and sometimes it's at odds with this, teaching of humility too. So I think people don't necessarily realize that it's good to advocate for yourself. I'm going to combine the last two questions. The one I want to make sure I get to, because it's really, well, all of these have been very positive. Sounds like your team in this program is doing incredibly important work. Thank you. You are positioning yourself as leaders and trailblazers for health system change. Are you collaborating with other hospitals in the city or province to share knowledge and best practices? And I think we've talked about that a bit. But the next question is, how can this program be woven into the Ontario Health Team program? And that'll be our last.
I guess fairly recently, there's been a group of Ontario Health Leaders,
hospital health,
and it's organized through Ontario Health actually, and it's Indigenous leaders at various different hospitals in Ontario who are gathering on a regular basis as well, just to share our learnings. And both yourself and Mike had shared about IHAN as well. I don't know if you want to build on that a bit more, Mike.
Yeah, I mean, I actually think we're starting to develop lots of these different connections. I think with respect to the OHT piece, how do we weave? Care happens, more care happens in the community than in a healthcare institution, but the transitions and the communication between community settings and hospital settings is challenging. Patients and families know that it's an inherently risky space, that transition between, into and out of a healthcare facility. So, the premise of OHTs is that we will have things more seamless and more communication. And I think when that vision is realized, our communities, but all communities will benefit from that. That's the vision, and the work is now getting there.
Yeah. Always more work to do. I'm going to pass it back to Christy to close. And thanks so much for all the wisdom that you've shared.
Yeah, thank you to all of you for such an incredible conversation. You know, I know I have learned a lot, and I am really hopeful that you continue to be successful in moving the work that you do forward, because, you know, what I got out of it is it's all based on compassion and kindness and being true to who you are, being true to the patients that you serve. And, you know, I think that there is a courage in that. And, you know, I want to thank you for being courageous and, you know, for doing what is right. You know, you are incredible champions for the Indigenous community. And, you know, obviously your passion has just, you know, shone through just in this 1 hour. So, you know, I'm incredibly grateful that you were willing to be here and that you were willing to share. And, you know, I hope we have the opportunity to do this again with all of you. So, so to the rest of you who are watching, that brings us to the end of our session. I hope you have all enjoyed today's behind the scenes presentation. It's really important for us at the foundation to have the opportunity to show all of you, you know, how your generosity is fueling so much work that happens at our hospitals. And, you know, hopefully you know that the impact you're having on patients is happening every single day. So for those of you who are so inclined, a recording of the presentation will be available on our foundation YouTube page, should you want to view it again or share it with your friends. Thank you once again to all of you, our panelists. Thank you, the IHP program. Thank you for being with us. Thank you to our viewers for joining and for your continued support of our hospitals. I wish you all well, and I hope to see you all again soon. Thanks.